Hi, I'm Dario Cortez. Berkeley College believes that all citizens need to be informed about the important issues that affect our daily lives. That's why we're proud to support programming produced by the Caucus Educational Corporation and the partners in public television.
Cardiac innovations next on Caucus, New Jersey.
Funding for this edition of Caucus, New Jersey has been provided by Englewood Hospital and Medical Center, QualCare Inc., a local managed care company covering 750,000 New Jersey residents, and by New Jersey Natural Gas, proud to support education in our communities.
Welcome to Caucus, New Jersey. I'm Steve Adubato. Cardiovascular disease is still the #1 killer in America. When dealing with issues of the heart, situations can often become critical. Joining us here in the studio to discuss the newest cardiac innovations are Dr. James Klein, Chief of Cardiothoracic Surgery at Englewood Hospital and Medical Center, Erin Mahoney, Director of Case Management at Healthsouth Rehabilitation Hospital, Richard Kushinsky, who is a heart patient, and finally, Victor Fabry, who is a volunteer with Mended Hearts. I want to thank all of you for joining us. Listen, cardiac innovations. Doctor, what kind of innovations are we talking about? By the way, throughout this entire show, you'll see websites where you can get additional information because we only have the ability to bring this to you for the next half hour. Follow up. It's important information. What innovations?
Well, one of the biggest innovations at our hospital over the last decade or so is to try and perform complex heart surgery without the use of blood transfusions.
How do you do that?
Well, it's...
Don't say it's very difficult. How tough is this?
It is difficult, but the game is not necessarily won or lost in the operating room per se. The game is won or lost by preparation before surgery, as well as what goes on during the operation and afterwards.
For example?
Well, we try not to bring someone to the operating room if there are things that we can correct regarding a low blood count or things that should be addressed prior to surgery. We're very, very meticulous in the operating room. We have some special techniques and machines that we use to conserve blood in the operating room. And afterwards, we pay strict attention to not ordering unnecessary tests.
Let's get real specific here. You are the doctor's patient.
I am. I'm very proud of it, too.
And you said before we got on the show...
Saved my life.
Why do you say that?
Well, because I had no symptoms before I had to have the surgery. I was perfectly normal. I played golf 3 days a week, went to the gym 3 days a week, went to my office every morning, and I had no symptoms whatsoever. I went to my doctor. They did a echocardiogram. They found I had an aneurysm, ascending aortic aneurysm. I went to see Dr. Klein, and it was 6.5, which would have been like a balloon, would have burst. I would have died had it not been operated on. Had he not done what he did, who knows what I would be here today.
But where's the innovation there?
Well, for us, the innovation was to do such a big operation. Mr. Kushinsky needed a bypass for a blocked artery. He needed a new valve, and he needed his ascending aorta replaced. We were able to do all of that without a blood transfusion.
This is interesting. What's the advantage of not having the blood involved? Because we're going to talk about rehab and all the other physical, clinical, and also psychological and emotional issues associated with that in a second. What are the advantages after the fact, doctor?
Well, administering blood, although necessary in some particular circumstances, administering blood is like administering medicine or a drug or putting something into the body that the body is not used to seeing. So there are inflammatory reactions, there are changes in the immune system, there is a higher chance for an infection, and we think that these 3 or 4 things can be almost eliminated and lead to a more rapid recovery with less side effects, less complications, and hopefully our colleagues on the other side and the rehab centers are seeing that.
We're going to talk about that. Go ahead, Richard, then we're going to rehab.
Just one thing.
Sure.
I think what I want to say to everybody is that go get checked out, because I had no symptoms whatsoever. If you have a family history, which I do have of aneurysms, that should be a telltale for you to go get checked out by a doctor to see what your situation is.
Sure.
You know,
Erin, let's do this.
It's very important because my experience, I had some symptoms, but they were misdiagnosed. Difficult breathing, a flu-like cold that lasted for 6 weeks. And eventually I was diagnosed with the same situation as you.
And you would not have known that?
I would not have known until I went to my cardiologist, and they did some additional tests, and they found out that I didn't have a flu, I didn't have a bronchitis, I had an ascending aortic aneurysm, similar to you.
And by the way, while we're getting ready to talk about rehab, some of the other issues, or some of the other innovations, if you will, in terms of cardiac care, valve replacement becoming very common in those who are older. Use of animal and medical valve, correct so far?
Animal and metal valve.
Excuse me, animal and medical. And the aortic aneurysm, which my dad had, a widening of the aorta, can be deadly if not caught early, correct? That's what we're talking about?
Yes.
Now, let's shift. Erin, the rehab process.
There are 3 processes in rehab.
Look at you answer my question
I'm
before.
sorry.
No, that's good. I think you probably have it right.
Because I'm listening to everyone.
Go ahead, jump in.
And there's what's called phase 1, which is inpatient rehab.
Phase 1 is inpatient. By the way, when you log on to our website, we'll connect you to others who know more than we do. Phase 1.
Phase 2, outpatient rehab, means after you finish the inpatient and you're back home and you see your physician, and then they recommend an outpatient program. It's a little bit more strenuous than the inpatient program. And then there's phase 3, which is when you're finished being monitored. You still need to watch out for your heart, and a lot of the patients that are cardiacs go back to where they did their phase 2 program, and they have a non-monitored program, and the patients go there.
But hold on. At HealthSouth, your operation is inpatient.
We're inpatient, and what happens is after the patient has surgery, if they're a congestive heart failure patient, if they're a patient that's had bypass or valve surgery, they can come to us.
10 days?
7 to 10 days.
Got it.
10 days is like the longest usually. It's an acute rehab, so what happens there are physicians on staff, there's a physiatrist, a doctor of physical medicine, regular medical doctors, cardiologists that come in on a daily basis. The people that are watching the patients on the monitor are trained employees. They're either a nurse, they're I'm sorry.
Well, no, all the clinical folks are involved.
Right,
What about the
respiratory
family
therapy.
in this? Because I'm pulling Victor in, because I want to talk about the depression piece in a moment. Families
family is
essential to the rehab process?
essential.
Because?
We do, it didn't just happen to the patient, it happened to all the family members that are in that family, from the spouse to the children. So we bring them in, we do counseling, we have a counselor that works with them, we do nutrition counseling for them. It's not just the physical rehab, which is what we do.
Whole family.
It's the whole
Victor,
family.
talk about this, because I'm blown away by the numbers here.
I agree.
Depression is very common among heart patients?
What I see, I visit patients every week at Morristown
What is, by the way, what
Memorial.
is Mended Hearts? I want to make sure people know.
Mended
what it
Hearts is a national organization of volunteers,
is. A nonprofit.
nonprofit, open heart survivors, and survivors of angioplasty procedures like stents. But what we see is, what I see, I've observed in the last couple of years that I've been doing this, about a quarter of the patients after surgery exhibit symptoms, to my untrained view, of post-traumatic stress.
Post-traumatic stress.
That's
You're talking about something that people would connect to being in a violent incident or a war.
the trauma that a patient would undergo with open heart surgery, and the questions he might ask or she might ask themselves about their future, right, is quite traumatic. So what we do is we try to visit a patient, give them support, try to relieve some of their anxiety, and we talk. One of the major things we discuss with them is cardio rehab. I tell the patients, you know what, you should absolutely get involved in cardio rehab program, either at this hospital or a local hospital to you. They've been doing studies, and they found that patients that go through cardio rehab recover quicker, live longer.
Doc, jump back in. How important?
I agree with all this. I think it's been very well said. So severe life-altering depression, not terribly common, but that middle ground, the blues, the
Is it questioning of yourself?
Yes, exactly.
What are you
Thank
questioning?
Well, I was talking with Victor before we sat down, and you know, most of my patients, frankly, on the first or second day are thrilled that they're alive, have that initial euphoria, gee whiz, I did it. And then days 3, 4, and 5, you start to see a little bit of that almost self-questioning.
Of what, though?
What exactly happened to me? How close was I really to not surviving? What does the future in the short term look like for me? What does the future in the long term look like for me?
What about my family?
And how is my mother, father, sister, brother, children going to treat me? My interpersonal relationships with my family, am I going to be looked upon as
less than? I see
think
Richard.
You have two very good.
Richard's shaking his head. I'm sorry for interrupting, Doctor. I see you want to jump in. Go ahead.
The only thing I wanted to say was, you know, I'm 78 years old, and my fear
Are you
was,
really?
Yeah, my fear was not of dying. My fear was that I would wake up with brain damage. Something I was afraid of. Okay.
Going in.
Going in. When
he
I
say that
woke
to you?
up, we talked about that.
Yes, but his operation, his aneurysm, the fear of interruption of blood flow to the brain is actually very pertinent worry.
Legitimate in that case.
In this particular.
So that was my fear. And when I woke up and I was fine, I was tickled pink to be here. And I never had any depression. I've
Never.
not had, no. But I've gone back to my routine. I go back, I teach at art school. I teach, I go to my law office. I go to the gym. I go to my cardiac rehab. I started at Healthsouth.
For the 10 days, right.
Right there, and they do a terrific program. I want to tell you, that's the third time I've been there, twice before for hips. But this for the heart. The heart program is wonderful because
At
they
Healthsouth.
put
Anymore, we'll be plugging them too much.
well, no, the monitor.
I didn't
PBS.
ask him to say that.
I know.
She didn't-
Don't get defensive. I know you didn't ask him to say it. He was
she
just saying
doesn't-
something
she
nice.
doesn't know that I was there. I mean, I was there.
No, I got it.
Okay, but they really do. They put you on a monitor. They take you in. They make you do. You have to walk. You have to, while you're in the program.
No, I got it, but I want to get back to the psychological
Sure.
piece here.
Let me respond, Dick.
Sure.
This is my experience, and I consider myself very lucky.
You describe exactly what you had, Victor.
After the surgery, a day after the surgery, I was considering how fortunate I was. But then in the same thought, I wondered why this had happened to me, which is a negative thought. Why was I burdened with this problem? Why did this happen to me? And within a few minutes, my mind flipped around, and then I wondered why I was saved. Why was I chosen to survive a 6-hour operation and replacement of an ascending aorta with a piece of plastic and replacement of a valve, my own valve with a CABS valve? So that type of difficult dichotomy of thinking is unsettling. I was lucky that it passed, and the following day, I never gave it much additional thought.
But you had support around you?
I was very lucky. I had my wife. I have 2 daughters. They were by my side, and those were the most important support systems I had.
But again, what happens for people who do not have such a strong family structure around them? Erin, what happens in those cases?
In those cases, in the hospital where I work, we do have a licensed clinical social worker that works with the patient. The case manager's job is really to make sure when the patient goes home that everything they need is set in place, whether it's community agencies that we use, like the visiting nurse, because they have something called telehealth that can watch the patients at home. And then a lot of insurance companies give them social worker visits also, so they can go out into their home and help them also. But family support is truly important.
And by the way, log on to our website. We'll connect you to nonprofits, health-related organizations who have valuable information about this complex set of issues around cardiac innovations. Doctor, I need to ask you, as you're going in to do what you need to do, whether it is for Richard or your other patients, At what point do you begin to discuss in a very serious way nutrition, lifestyle, and the changes that need to be made?
Yep, that's part 3 of what Erin was talking about earlier. At your initial visit with your patient, most people don't hear that. Most people...
Just get me through this.
Correct. And we like to see our patients about 4 to 6 weeks after surgery for their follow-up visit. And at that time, we talk a little bit about, gee, you may feel like, you know, you're a lucky man because you survived such a big operation. But let's talk a little bit about how, and this is the way I like to phrase it, how to make the operation last as long as possible. And those are the other components: staying with your doctor and taking the medicine that's been prescribed, staying with your Part 3 rehab program and trying to keep the weight off and not smoking and having your diabetes controlled and watching your cholesterol, and also participating in a long-term rehab program where you can get some help from some of your colleagues on the treadmill together. Hey, I had this operation, I had that operation, participating in exercise and things that will help the surgery last as long as possible.
Is it tricky sometimes because we're talking about cardiac innovations and the technology is moving so quickly? Is it tricky sometimes that people think, oh, the technology is so great, the medical community is able to do things that heretofore they weren't able to do, so I don't have to do that much because medicine's amazing? That only goes so far. You're shaking your head again.
Well, no, I'm just saying it doesn't work.
It doesn't work that way, right?
No, it doesn't work that way. You'll be dead by the time that innovation is going to help you. What you got to do is help yourself. And I go to rehab. I go to cardiac rehab 3 days a week. I go to the gym twice a week.
Right.
I watch my diet very carefully.
You're very self-motivated.
Well, I want to live. I have reasons to live.
No, I hear you, but we'll go back, Erin. How much of the nutritional piece and the exercise piece that Richard's talking about right now, how often do people have to be pushed? He doesn't have to be pushed. He's obviously self-motivated.
He's self-motivated, but there is a lot of people we were discussing before that once they feel better and they think, okay, it's over and done with, it really isn't. You think about your parents, my parents' generation. They grew up sometimes on TV dinners, Campbell's soup. There's nothing wrong with those things, but they're high in sodium. So we teach people just easy aspects of nutrition. Look at the labels. Look at the labels.
Give us some do's and don'ts.
And
we'll have a full list on the website, but some do's and don'ts now. You should be eating what kind of food?
Healthy vegetables, lean meats, chicken. They say, what, pork is the other white meat, I guess. They do explain to you how much the nutritionist says, you know, for calorie intake for what you're allowed to take, about, you know, the size of your fist.
Steve, I can add to what Erin has just said. We talk to patients about being cautious about certain elements in the diet.
For example?
As an example, if you've had a valve replacement or open heart surgery, certain things like caffeine can trigger tachycardia, arrhythmia.
Really?
Nicotine raises your blood pressure, and obviously if you have heart disease, increased blood pressure is not a good idea. There's also indications that sugar, raw sugar, sweets, and alcohol have to be watched because they can encourage problems that sometimes can occur after open heart surgery.
Doctor, fair to say that, going back to the question I asked, which both of you added to very effectively, that you struggle with the question of having people understand that these innovations are terrific. I mean, if this had happened to you 20 years ago, 10 years ago, you might not have had this shot, but it's just beginning.
What's just beginning?
Listen, I know, yes, you had the operation now, this procedure's available now that wasn't available before, but now we're dealing with smoking. We're dealing with alcohol. We're dealing with caffeine. I'm sitting there as I went to my Starbucks on the way here, and they're not a sponsor. I just like to pay more than I should for my coffee.
It won't be a sponsor now.
Well, thank you for sharing. And some of the other things you talked about. By the way, it was caffeine, it was
nicotine, sugar, meaning pies, sweets, and things of that nature, and as well as alcohol.
And salt.
And salt.
Sodium.
Oh my God, it's salt too.
Essential.
What's left?
Well, It's
Good fats,
yeah, it's
Okay,
impractical.
good fish.
It's impractical to tell a patient to stop everything, and you know, people aren't very good at all or nothing.
Is it the moderation thing?
Yeah, I am a little bit on the moderation side. You know, if a patient asks me, is this it for me for red meat? You know, I would probably lean towards saying, well, why don't you go with twice a month instead of 3 times a week? Or if the patient says, am I done with, you know, apple pie? I might say, well, Thanksgiving is a perfect time to treat yourself a little bit. But modification of the diet and the lifestyle that help bring you to the operation is what has to help make the operation last as long as possible.
And speaking of lasting as long as possible, we're going to put up the website for the American Heart Association, our colleagues and partners in this initiative who, they've been at it for a long time, and they have very valuable information. Go on to that site looking about information about nutrition and rehab and exercise and et cetera, et cetera. Couple minutes we have, about 6 minutes left. Doctor, other innovations, because I jumped through these kind of quickly.
Well, I'm glad we came around to that because we started talking a little bit about what to do about patients who need so much help on the outside when they're recovering, whether it be physical, emotional, psychological. And you mentioned earlier you were surprised how much valve surgery was done. And what we're seeing is that as Americans do live longer, we're seeing valvular heart disease catch up to coronary artery disease.
Explain that.
So the most common valve to wear out as we age is the aortic valve. Both of these gentlemen had their aortic valves replaced. And as Americans reach their 7th, 8th, and even 9th decades of life, the aortic valve can sometimes start to wear out and scar down and calcify. And then it doesn't open correctly and it doesn't close correctly. The biggest valve innovation on the forefront is the ability, just like we can open an artery with a stent, is to eventually be able to implant a valve in a similar fashion through a catheter, like a large stent.
Why is that such a big deal?
Well, we think that it will help bring some of the higher risk patients who we're worried would not survive conventional heart surgery, like these gentlemen had, to a little less invasive, less aggressive type of operation. It will still be a procedure, it will still be an operation, but it might afford some 80-year-olds, and this population is expanding as we age
growing.
longer.
Just to add to that, they just did one where an 85-year-old man.
And what?
An 85-year-old man with that procedure. It was on the news just recently.
Right. So as people get older, the aorta becomes more of an issue?
Yes, the aortic valve and the aorta, but the aortic valve, as we age, tends to wear out after opening and closing 70 times a minute for 80 years.
I'll give you a couple, we've got about 2 minutes left. I was wrong before, we didn't have 6, we had 3 minutes. Any other innovations you want to put out there?
The third is we're always looking to change the approach to the operation to produce more benefit and less risk to the operation, and that's where some of these smaller incisions come into place, or less classic incisions come into place, and you might hear about minimally invasive heart or lung surgery.
Minute left, going to go around real quick, yes.
I just wonder why we didn't have to take any kind of medicine when we had the plastic put in ours for rejection.
Yes.
Why doesn't that have to be done anymore?
Because none of those items have antigens on them, so the body will not recognize them and form antibodies. So these devices cannot be rejected because they're
Look at Richard asking questions. He have his own host his own show in a couple of weeks.
No, because
real quick.
I was concerned about it.
No, that's a good question. Real quick, go.
Dick, I have some good news for both of us.
What's that?
After my surgery, my cardiac surgeon said, Victor, when you need your next valve, it will be done percutaneously or through a procedure that's relatively non-invasive. So we have that to look forward to. If we need a new valve,
Well, about 105.
we're not going to have open heart surgery again.
Erin, you get the last word. You've been doing this for a couple of years.
I would just like to say that a lot of people are worried about their insurance, whether it's going to pay for everything, and the insurance really has caught up. Valve surgery didn't used to be paid for in an outpatient rehab, and they pay for it now. So Don't be scared. The American Heart Association sometimes says, you know, some people, there aren't as many that should be in cardiac rehab.
The preceding program has been a production of the Caucus Educational Corporation, celebrating over 20 years of broadcast excellence. And 13 for WNET, NJTV, and WHYY. Funding for this edition of Caucus, New Jersey has been provided by Englewood Hospital and Medical Center, Qualcare Inc., a local managed care company covering 750,000 New Jersey residents, and by New Jersey Natural Gas, proud to support education in our communities. Promotional support provided by NJ Biz, All Business, All New Jersey, and the Star Ledger and NJ.com, Everything Jersey. Transportation provided by Airbrook Limousine, serving the metropolitan New York, New Jersey area. Caucus, New Jersey has been produced in partnership with TriStar Studios.
I'm John Campbell, Berkeley College, class of '98, associate's degree in paralegal studies.
I'm Busi Matsiko Andan, Berkeley College class of 2004, bachelor's degree in business administration.
Melvin Montalvo, class of '91 and 2003, degrees in accounting and management.
Simi Papachin, class of 2001, bachelor's degree in business administration.
From different walks of life, our students succeed in different ways, yet their first step is exactly the same. Berkeley College.
Don't miss Steve Adubato and co-host Raphael P. Rahman each week on New Jersey Capitol Report, airing on NJTV, 13, and WHYY. Check your local listings.